Good morning, everyone, and welcome to another Changing the Way We Work Community of Practice for Ontario Family Physicians. My name is Ali Damji, and I'm the Division Head of Primary Care at Trillium Health Partners and a family physician at the Credit Valley Family Health Team, and I'm delighted to be your moderator today. Today's session is going to focus on AI tools for practice, some infectious disease updates, as well as looking at climate change and extreme heat. Um, we have a great set of panelists lined up for you today, and I'm going to turn things over to Dr. Verghese from the OCFP to introduce the session. If we can just go back one slide.
Thanks so much, and thanks, Susan. Um, just wanted to thank everybody for being here. This is a really interesting session that I think is going to be really timely and really has been asked for quite a bit. Um, we also want to make sure people know that this is a 1 credit per hour group learning session and has been already certified. If you note there's a little bit of a delay, we will be doing this for you after you signed up. Next slide. It is also remember that these are recorded, and after they're recorded, they still can be credits assigned for them. So as part of the self-learning program, you can earn credits for this, and the information is on the slide here, and we'll be providing this as well. Next. I want to take this time to do a land acknowledgement, a quick reflection before I hand back to Ali. We acknowledge that these lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognizes that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects that Indigenous people have rich cultural heritage and, rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new cultural safe relationship, and contributing to reconciliation. And so, as we think about the month of June, I'm still quite early in my own journey of truth and reconciliation. But June 21st marked National Indigenous Peoples Day, and it made me wonder why they chose a specific day. And it takes place on the summer solstice, longest day of the year. Um, and it's because many Indigenous people, Métis, Inuit communities have celebrated their culture, languages, and traditions on this time of year, because it holds such deep spiritual and cultural significance, due to the marking of renewal, connection, and celebration. And I think for all of us, this time of summer, it's a little bit of slowdown for some, not for others. It can be a time to actually look back and see how we can have some balance in our life, some integration of our work and life. So as we kind of look to the future in ways that AI can be helpful for us in our practices, or as we work with our patients that may be managing the summer heat, I hope everybody has a lovely time with us. And Ali, I'll turn back to you.
Thank you so much. And we'll move along now into the just a few of the introductions here. So, just again, a thank you to the Scientific Planning Committee for all of those involved, and thank you as well to Jobin for that great reflection and those great insights there. Next slide, please. So this will be the order of today's talk. So we'll start with the infectious disease update, then we'll move into AI, and then following that, we're going to discuss climate change and extreme heat. Next slide. So I'm going to turn it over to each panelist at this point to introduce themselves and make any disclosures that they may have, starting with Dr. Warshafsky.
Hey. Hi, morning, everybody. Daniel Warshafsky. I'm an Associate Chief Medical Officer of Health in the Ministry in Ontario, and nothing to disclose. Thanks.
Thanks and welcome back. Over to you, Dr. Alarakhia.
Yeah, I'm Mohamed Alarakhia. I'm a family doctor, and I'm CEO of Amplify, and I am the CEO, so it's a not-for-profit organization.
Thank you very much, and welcome back as well. And to our newest panelist, Dr. Green.
Yes, thank you. I'm a family physician at St. Michael's Hospital and board member with Canadian Association of Physicians for the Environment. That's a volunteer gig, nothing to disclose.
Fantastic. Thank you for coming. Over to you, Jobin. Oh, you're muted.
Thank you. Joe Verghese, President of the Ontario College of Family Physicians, and I'm also the Interim Assistant Dean of Primary Care Education at Toronto Metropolitan University School of Medicine and Associate Vice President at William Osler Health System. Back to you, Ali.
Thank you so much. As for myself, so I do receive honoraria from the OCFP, the OMA, Trillium Health Partners for my leadership roles, the CMHA for educational consulting, the Center for Effective Practice, and one-time honoraria once from GSK. And I do serve on a few advisory boards, including the Medical Post, the Foundation for Advancing Family Medicine, and the Center for Effective Practice. None of these pose a conflict of interest for my role today. Next slide. So as a reminder to our participants, all questions need to be asked using the Q&A function on the bottom of your screen. Please also take a look before you post a question to see if someone's already asked the same thing. And if they have, please upvote those questions because those are the ones that I will ask, the ones with the most upvotes. For the chat, I see people are using it already, which is great. Please use it to wish each other good morning, let us know where you're coming from, and also for networking as well. Next slide. So again, this will be our order of our panelists. So I'm going to turn things over first to Dr. Warshafsky. Next slide, please.
Great. Thanks, Ellie, and morning, everybody. This is just a very quick update on the current state of affairs for avian influenza. So if we go to the next slide, please. So avian influenza, I think for people familiar with it, it's been mentioned before on this talks, that over the last year, in 2024, we started a pretty significant increase in cases of animal avian influenza. So obviously the huge outbreak within dairy cattle in the US, but a lot more detections in both avian and non-avian animals in Canada, as well as one human case in Canada. Since that time, it's been essentially stable with that change. So we're still seeing increase over previous seasons, but we're not seeing any sustained human-to-human transmission, and the overall risk remains relatively low, outside of some very particular occupational health settings where people might be exposed more regularly to potentially avian influenza. So next slide, please. Health Canada announced that the federal government had procured an amount of Arapanrix is the name, but it's an H5N1 vaccine, and that's been purchased already by Health Canada for use across the country. And at this point in time, most provinces and territories are still in the initial phases of just rolling out what they're going to do with this product. Again, not knowing that it's essentially just the higher occupational risk at this point in time. NACI did put out some general guidance about what groups you might consider at different phases of how much H5N1 we're seeing. And really, most PTs at this point, provinces and territories, are going to stick to a very, very narrow use. So the vaccine itself is a 2-dose series. It's 21 days apart. We want to keep it separated from particularly the seasonal flu shot by at least 6 weeks to ensure we're getting good protection against both things. But there's also a lot of question about this vaccine because it hasn't been used very, very often. We really don't know how long the protection might last. So it's really something that's going to be offered to highest risk populations, but still lots of unknowns about how much protection it's going to offer for how long. So if you can go to the next slide. So in Ontario, so information went out to public health units earlier this week. The publicly accessible website on the ontario.ca should be up probably early to mid next week with this information. But the program is going to start rolling out in the next few weeks. So just you may start getting questions from potentially workers that are going to be more exposed. But there's two primary populations that we're going to be immunizing in Ontario. First is people who have ongoing contact with birds that are likely or potentially going to be infected with avian influenza. So this includes wildlife officers, researchers, rehabilitation, anybody who's handling sick or dead birds and exposed to those often, as well as veterinarians, veterinary technicians, and others who are exposed to sick or dead birds, particularly doing necropsies, for example. The other population that has a lot of exposure potentially to H5N1 is, of course, lab workers who are doing research specifically on culturing or handling live H5N1 virus. So as you can see from this list, it's a very, very narrow group of individuals in Ontario who are going to be eligible for this program. At this point in time, local public health is going to be reaching out directly to essentially the settings where they're working to let them know about the vaccine. But again, this is going to be public information on the website next week, and it has gone out already to all local public health units to start contacting. At this point in time, I think the main thing to note is that, farmers, particularly poultry farmers, and people working in that industry are not currently eligible. There's a few reasons why, but number one, those exposures are generally, if there's exposure, it's very, very, very short-lived, right? So for poultry, when they become infected with H5N1, we see mass die-offs, and then we cull the flock as soon as possible. So any exposure is going to be quite limited in terms of time. So it's really only those people who are going to be at multiple sites handling the dead birds, we have those wildlife officers that would be in the agricultural industry that would be eligible at this point in time. Next slide. This is just the link to resources. Again, the Ontario website that's linked there has the general information of avian flu, and it's going to be updated in the next week with information on the vaccine as well. But just wanted to make sure people knew what was happening with this one. That's it from me, Ali.
Amazing. Thank you so much. Really appreciate you always giving these timely updates, and that's really, really interesting to hear about these potential initiatives that are going on here. So there's a couple questions that we'll jump into right off the bat, and if people have more, please feel free to add them to the Q&A. So the first question is, there's a lot of viral illness right now, it seems, when we're in practice. It doesn't seem to be COVID. Does anyone know what is circulating right now, or could you give us an update on that?
Yeah, I didn't look today for what's on the Ontario, the PHO respiratory virus tool, but I encourage people to take a look at that. So obviously it has the big three, COVID, flu, RSV at the top, but if you go down a little bit, it has the next 10 that we follow: enterovirus, rotavirus, seasonal coronaviruses, parainfluenza. Last I checked, it was mostly enterorhinovirus. I think we were at like 10 to 15% when I checked a few weeks ago. I encourage someone to check right now, then you can just put it in the chat what we're seeing. But that's mostly what was circulating, at least earlier in the month.
Amazing. Thanks. Another question here comes from someone about the RSV vaccines and whether we're going to see any coverage for them at some point for older at-risk seniors in the community.
Yeah, I hope so. That's still under discussion for this season, and I'd say that we're hoping to hear something soon.
Okay. Here's another question from actually one of my friends here, which is the avian flu vaccine. Is it similar to the flu vaccine in terms of mechanism of action?
Yeah, it is. So it's still hemagglutinin, not neuraminidase that it's providing the antigen against. So this is the H5 specifically, although we know there's some degree of cross coverage we get from it. So it functions the same way. So if we're talking about, again, like how effective it is, how long it's going to last, probably similar to seasonal flu vaccines, which we know do not last that long. Maybe we get 6 months out of it, which is why it's really a question of the best use in these occupations where they're potentially being exposed repeatedly to avian influenza.
Makes sense. And in terms of the vaccinations themselves, like was there any consideration given to vaccinating those who actually care for people with avian influenza, like healthcare workers, infectious disease specialists, ER specialists, family medicine docs, anything like that?
Yeah, great question. And that was covered in the NACI guidance as well. At this point, again, we've had only one human case in Canada in BC. So the chances of a healthcare worker in Ontario caring for someone who has avian influenza is vanishingly small. If we see changes in the epidemiology, if there's more spread into cattle, for example, or we're seeing human-to-human transmission, totally different story. So this is the kind of thing that's going to be reevaluated regularly based on what the risks are. At this point in time, again, to immunize healthcare workers, they're very unlikely to see a patient while they have the protection from this. And then again, we don't not know exactly how long it lasts or what benefit will be later on.
Hmm.
There is also, with all these vaccines, like there's an issue of priming when you get your first dose, that if we prime you for this H5N1, how will it cover the next H5N1, right? If you've been primed against this one. So we always take that into account, which is why we try to keep these narrow to the highest risk groups.
Makes sense. In terms of accessing the vaccine itself, where do people go to get it if they are one of those eligible people?
Yeah, so their workplace setting will be contacted by the local public health unit. Some workplaces that have occupational health, so these research labs, for example, will probably be through their occupational health that'll be getting it. Otherwise, local public health units will be offering clinics specifically for those individuals who are eligible. If people aren't quite sure, but they fit those populations, they can always call their local public health unit.
Amazing, thank you. And just to confirm, someone did look up the dashboard, and they said that entero and rhinovirus are the highest at 10.5%.
I was pretty close.
Yeah, there you go. Awesome. And then the next question here, kind of on a similar line, is should suburban vet clinic workers also get this vaccination?
Yeah, it's a really good question. So more urban or suburban vets, they tend to see less birds, frankly. Like it's a lot of cats and dogs and small rodent mammals, that sort of stuff. And pet birds are normally, they have to be kept indoors. So the chances of them being exposed to avian influenza in the wild and bring it in is very, very low. So those types of vets aren't really at significant risk. It's really the vets working in the agricultural industry with livestock, like, doing those necropsies on the dead birds. That's who's really at the highest risk.
Makes sense. The next one here is about the HPV vaccine. So, will the HPV-9 vaccine schedule be updated in the next school year to align with the NACI recommendation for a single dose?
A really good question. It probably won't get changed for this upcoming school year, just given the timing that, we're in July already, and that's very, very soon. But it is being looked at both, moving to align with the NACI single dose, but also expanding to some of the additional populations that NACI talked about, particularly the higher age range. So that's under discussion, but it's very unlikely to be for this year.
Okay, thank you. I saw one question actually pop up in the chat, which I think is a good follow-up question, just going back to the vet clinic workers and the exposure to birds. What if someone has chickens in their home, like they just keep a few of them? Is that a risk?
Oh, I do know that people have those home chickens in Toronto.
Yeah.
That was very popular for a while. Generally not, right? So this is a very small number of birds, and they don't have exposure to other flocks. So part of the reason that we see things in larger agricultural centers are both exposure potential wild animals that might be carrying wild birds, but also transmission between farm settings. If you have like 5 chickens in your backyard, they're probably well contained and extremely unlikely to have exposure to avian influenza.
Okay. Next question here is about RSV again. So for the RSV vaccine, do we now know what the duration of the immunity is and that they need to reboost after 2 or 3 years, or is that still unclear?
So the data we have now for so Arexvy is one we have the longest data out to 4 years, and that's actually still showing really good effect at that 4-year mark. So NACI at this point has not given any direction on when we should have a booster. We're probably good for at least 4 years for all the products. Again, there isn't a reason to think that a different product's going to have significantly lower. So no boosters are yet being recommended. I think we are starting to see it wane a little bit over that time. So it's really trying to get a sense of what's the threshold when we think boosting is going to be most helpful. But at this point, there's no recommendations for boosters.
Okay, amazing. And then another question here, we're just getting towards the last few, is can we assume that all babies are now getting the RSV therapy, in hospital at birth? Is that?
Yeah, so they won't be getting it right now. So at this
Yeah.
point of the season, again, like it ended end of March or whenever the letter went out that everybody saw,
Mhm.
a little bit later than end of March. But given the short duration of protection, so we really only have 6 months of protection from the RSV monoclonals before this nirsevimab is the one we have. So giving it now would not be helpful for those kids to cover them through the season, unfortunately. There'll be information coming out really, really soon about when the season's going to start. But it'll be again in the fall, in October, like we had last year. And really, it's getting hospital births and community catch up starting at that point in time so that we can ensure that any of those infants are covered through the duration of the season. If the question was, do we assume that all babies starting in the fall will be getting in hospital? I wouldn't assume all necessarily. Like there's still many parents are still potentially going to decline or not sure about it. We know that the number one reason that parents waited last year was they wanted to talk to their primary care provider to ask a little bit more about it before getting it in the hospital setting. So it is going to be covered in the fall. They're not getting it now.
Okay, thank you so much. And I'll maybe do one last question here, which is, will the Novavax be available in the fall?
It doesn't look like it. So what we've heard from Health Canada and the manufacturers that they just don't have supply available for Canada this year. So probably this fall is only going to be the mRNA products for COVID.
Okay, thanks as always for being so clear, answering all of our practical questions. There's a few more, Dan, if you'd like to respond to just by typing out, and then we'll move on to our next speaker.
No problem. Thanks, everybody.
Thank you. Amazing. So over to you, Dr. Alarakhia.
Great. Thanks very much, Ali. So we talked about avian influenza. So now we're going to talk about another AI, artificial intelligence. And my hope today is to talk to you about some very practical tools in AI and how you can use them in your practice, and then talk to you about the future and where things are going. So we'll go to the next slide. And this is really based on some of the questions that came in before this session to address the things that you are really interested in learning about. So we'll talk about how do you answer your medical questions, what tools can you use. We'll talk about this exciting area of agentic AI, which I think is going to be the next game changer. We'll talk about AI scribes. There's lots of questions about clarity on AI scribes. So I'll talk about that, the two programs that people are thinking about. and where AI scribes are going. And then we'll talk about different tools in the AI journey to really support the care that you provide that are also on the horizon. We'll go to the next slide. Just to sort of say, Amplify Care, formerly known as the eHealth Center of Excellence, is a not-for-profit organization that came from primary care, and we're really dedicated to supporting primary care. We've supported over 16,000 family physicians and nurse practitioners in Ontario with a number of different services to help get digital tools into the workflow of clinicians, including change management and practice facilitation. We'll move to the next slide. And so one of the questions that came up was about when you have a medical question, where do you go? And it's very tempting to go to ChatGPT. If you search in Google or Bing, you get that AI summary, and that can be helpful. You're a medical expert; you can contextualize information, but there are also risks to that. So those models pull from the general internet. That's anything available on the internet. And they're actually designed to give you an answer. So even if they don't know the answer, they'll try to find an answer, and they will actually make up references. So they will find the best authors in that subject, they'll find the best journals, and they'll actually make up a reference. And so it's really tricky to know, unless you dig into and look at those references, if it's legitimate or not. So there needs to be an alternative, and this is one alternative called Open Evidence. The website's at the bottom there. There's also an app. And this is free for clinicians. So if you sign up, you need to provide your medical, it's called the I'll just get the name here. It's called the Medical Identification Number for Canada. You can actually find that in your CPSO account. And if you put that in when you sign up, you will get free access to that. If you don't put that in, you get a limited number of queries, and then it stops working for you for a time. Thanks, Chandy, for that. So if you actually put that in, you can ask it any medical question, and it only looks at the medical literature and gives you some really great answers. I've shown it to colleagues. I've shown it to colleagues in different specialties, and they think like that's the latest evidence that it's actually citing. You can actually ask it to say, like, look at the Canadian guidelines, and it will give you an answer based on Canadian guidelines. So this is really great at summarizing things. It gives you the references, so the actual references, and you can look those references up. So I use this very regularly in practice. It is very tailored versus like looking through a database and where you're scrolling and scrolling and scrolling. This will give you the answer to the question that you are asking. So try it out, see if it works for you. There's other tools out there. There's one called Hippo AI from Pendium Health as well that searches for Canadian guidelines. You can try that one out for a month. So it is, there are tools out here that really decrease the risk with searching using AI. AI is great to summarize evidence, but it depends on what evidence is looking at. And Open Evidence looks at only the literature. So something for you to try out. We'll move to the next slide. Agentic AI. So this is AI. This is AI that performs a goal, and it does so in an autonomous way, and it's adaptable. A great example of this is self-driving cars. Self-driving cars will get you to a destination. They will look at what's on the road, and they will navigate on the road, and then they will reach the destination. And so now there are a bunch of different tools, and I'll give you some examples next, that are being used in healthcare where the same thing is happening. So, and I'll give you a very practical tool on the next slide. And so agentic AI is helping in different areas. These are AI agents, so you can think about virtual people that are supporting things like triage. They're able to interact with patients by voice, so it's talking to a patient, sounds like a real person, and it's able to triage the patient and get the patient to the next step. So does the patient need to be seen right away? Can the patient wait for a couple of weeks? Is it an emergency? AI is very good at doing that. And coupled with that, it can actually book the patient into an appointment and schedule the patient into clinic in an appropriate amount of time. AI has been shown in studies, these AI agents, to actually schedule better than staff in terms of getting patients in a timely way and actually saving some of the same day spots for those who actually need them. These agents are able to remotely monitor, help with remote monitoring. So you think about a heart failure patient, which you are looking after. They're able to actually look at the patient's own patterns and say, hey, your weight is up. You need to take a diuretic or reduce salt intake, and really able to interact with the patient to help the patient, be in the community and not go to the ER. In terms of diagnosis and treatment, these AI agents are able to develop treatment plans, like customized treatment plans for patients, and really able to tailor it to the patient's background and the type of food they eat and what's happened in their care. AI is able to, in terms of monitoring, able to help with medication management, really supporting the patient in terms of what medications to take, and really being a patient coach overall, helping the patient through any sort of transition in care. And so this is not pie in the sky. It really is real thing. And so if you go to the next slide, the AI receptionist is here, and I'll give you an example, and you can try it out on the next slide. Actually, it does these things that were on the previous slide. It can triage patients, it can provide information to patients, and it can book patients into an appointment. We'll go to the next slide. Here's an example. Strello is a company. This software is integrated with TELUS EMRs and Accuro EMRs, and you can actually try it out. So if you look at the number on the bottom there, you can actually try out the AI agent, call it, and it answers, and you're able to actually have a conversation and as a patient, pretend you're a patient, and it will actually book you into a schedule, a virtual schedule. But so and clinics are using this today. So I'd encourage you to try it out. Just very quick anecdote. We had a pane of glass that was broken. I called a random glass care company in the area, and I spoke to Sarah. Sarah was tremendously empathetic. Sarah gave me a quotation, and Sarah, booked someone to come in and fix the pane of glass. And Sarah was an AI agent, and I didn't notice till the very end when there was a little bit of repetition. And so that a random glass care company in my region is using that. This is something that is going to become mainstream for us, and really with the shortage of administrative staff, this will be helpful, and this will allow administrative staff that you have that are extremely valuable to do other things like helping patient navigation and supporting you in different ways, decreasing burden on the clinic in different ways. So, a really neat tool that's here that one can try out and see if it works for you or not. We'll move to the next slide. Okay, so another big question that sort of come up is the AI scribe programs. There are two programs. What's the difference between the programs? There's a Canada InfoWay AI scribe program, and then there's an Ontario AI scribe program. Both programs did a great job of looking at the vendors, making sure they met privacy, security, and clinical requirements. So either program that you move forward in, you're going to get vendors that meet those requirements, vendors that have good contracts. They may be slightly different. Some vendors have similar contracts, the same contracts essentially between the two programs. Others may have slightly modified it in the program, but rest assured you're going to be able to get a technology that's been vetted to a high degree, and you should be comfortable using any of those programs. The Canada InfoWay program has 10,000 fully funded licenses for 1 year. The Ontario program has discounted pricing that changes based on how many people actually move forward. So that's a sort of a difference there. There were 9 vendors that were qualified on the InfoWay program, and then 20 in the Ontario program. And you can use the QR code there. If you scan that QR code, it will take you right to the registration for the program, and so you can sign up for this. And you've seen the data. This is a game changer in terms of time saved, after hours time saved for clinicians. We'll move to the next slide. And so these are a bit of eye charts, but this really is information that InfoWay has published. A very common question: how do you compare the scribes, the AI scribes? And so this actually shows you how you compare them. You can go to the website. You can, if you scan the QR code there on the slides that will be provided, you can go to the website and you have this chart available. How do they, work offline? What are the capability with systems? We'll go to the next slide. what are the different features? And you can see there's a lot of similarity, right? There's very few differences between the scribes, and really, like, you need to pick the one that works for you. Try a few out, pick the one that works for you, and they're all like really good. This deals with multilingual support, so different languages, multi-speaker support, so that's a common one, and they can manage that as well. We'll move to the next slide. Privacy security, as I mentioned, they looked at privacy security, including data residency and also other areas, user support in terms of things like change management, onboarding support. All the vendors provide that support, so that's available. We'll move to the next slide. And then EMR integration. And we know from recent data that EMR integration is important. It actually does save you time. And so here's the vendors and which EMR they integrate with. So this is for Accuro. Single sign-on is the ability to not sign on again. I sign on to my EMR and then I launch the scribe. Patient context is where I launch the scribe, and it's in the patient's chart. So the patient information is there. And then there's the one-click transfer to the EMR is once I'm done the talking to the patient, if I want to get it back to the EMR, it's not a copy and paste. I click a button and it goes into the EMR. And so these different features do save time. We'll move to the next slide. And so here's the ones that are integrated with TELUS Practice Solutions suite. We'll go to the next slide. And here's ones that are integrated with some other EMRs as well, including Oscar there. So this is, we will provide the link for this afterwards, and you can look at that to sort of see which one's relevant to you. We'll move to the next slide. And so where are scribes going? It's really exciting in terms of how fast they are developing. The scribes are moving towards being voice assistants, so that you can, not only does it record what you do with the patient in terms of documenting that, but you can say, oh, and do this, order this test, or I want the patient should follow up, and the scribes will help facilitate that moving forward. Scribes will be able to provide real-time translation. So you're talking to the patient's talking a different language, it will be able to translate that for you. So you can, then sort of say something back in English, and there are technologies where that will also be translated, but at least you can understand the patient in terms of real-time translation. They will provide decision support. So like if you're talking to a patient and they have heart failure, and you talk about a few medications, it might say, hey, did you try this medication? There's still a ways to go for that, and in terms of having the data that feeds into that, but that's certainly coming. And then finally, they'll be able to pull information from your EMR and process the information that's already in the EMR and use that to help you at the current visit. And then scribes will also do follow-up actions in terms of automatically setting up lab orders, automatically setting up diagnostic imaging requisitions, and supporting, and some of them, they already do sort of help you prepare a referral. So really exciting space. There are new things sort of coming all the time, and that will continue to evolve. We'll move to the next slide. And then the final thing is, if you look at like how you're caring for a patient and the different tools that you need. We talked about triaging and supporting that, and provincially, if you're familiar with the Health 811 service that replaced telehealth, it uses ADA, and ADA is a tool which actually has a conversation with the patient, it asks appropriate questions so that it can triage the patient to, okay, the patient can wait and see the primary care physician, or needs to be seen sort of more urgently, or needs to talk to someone more urgently. And it's well-established technology that does that. So helping with triage, and in fact, these tools can take that information and you have it available for you, so that when you talk to the patient, you already have that information, and you're not starting from scratch. There's tools that help with diagnosing patients that will allow you to sort of find patients that you may have missed or that are not sort of identified in your medical record. So Virto Health does that. We've actually procured that to support that function. It can find patients who have depression, heart failure, COPD that you actually need help with. Cure Health is another one. There are tools that actually suggest treatments for you. So what, as I mentioned, what treatment should this patient be on? So Pentavere is one that does that. And then the follow-up action. So there's AI scribes, as I mentioned, and virtual assistants that will actually take what happens at a visit and say, here's the next step for you, and it will actually carry out the next step. And some of them you will you will have to sort of sign off on. So there's a lot of development in this space. I will say a number of these things need to be vetted still. And so there's work underway to look at how do you vet these tools to say this is what you should be using, and these things have really passed through sort of and are okay to use. So more information will be coming on that. And we'll go to the next slide, which is the final slide. Really appreciate your attention, and I'm happy to take any questions.
Fantastic. Thank you for that overview. And I think a lot of us have our heads spinning with just all of the possibilities here. And there was definitely a lot of active concern and questions and activity in the chat as well too, which is great. So I'm going to jump right into some of these questions here. So the first thing about the agentic AI that you showed before with all those different pathways, is that being used currently anywhere at the moment?
Yeah, so as I mentioned, eHealth is agentic AI, where it's actually asking the patient questions and then taking patient to the next step in terms of what patients need. So it's used in the provincial level in Health 811 currently, and then the AI receptionist is being used by a number of clinics to actually help them today. So and in other industries, it's being used a lot, really for like a customer service role where it's interacting with people and helping them through sort of any problem they have.
Thank you. And I guess like from a specific clinic standpoint though, like are there actually like clinics that you're aware of that are using these types of tools like already
Yes.
in practice? Yeah, they are.
Yes, yes, yeah.
Yeah.
So the one I mentioned, the Strello one I mentioned, it's being used in clinics today.
Fantastic. That's awesome. And do you know if Strello's linked also to PS? I think you mentioned Acuro, but is it
TELUS.
also linked with
Yes,
PS as well? Tell
yes.
us. Fantastic. Thank you. And then there are a few questions here, and I'll just acknowledge them for the audience. Like I do see the questions about a particular scribe that's here that did not make the list. I just want to clarify though that Mohammed's not representing like the organizations that decided on like which scribes met criteria versus not. So if I'm not asking those questions, I promise to our audience, it's not that I'm censoring them. It's just that this isn't sort of the right person to ask about that. What I will say on it though is I'd encourage you to read the message that came out from Ontario MD, I think earlier this week. It's in their eHealth tips, and it talks a little bit about this. It specifically highlights the fact that they didn't exclude companies just because they weren't based in Canada, for example. So I think there's a bit of, some information that's not true that's being circulated there. Like they did consider non-Canadian companies too. So essentially they said if they didn't make the list, it's either because the scribe didn't apply or they did not meet the criteria that were set out by the vendor of record process. I'm again not a spokesperson for Ontario MD by any means, but I would just encourage people to read that email because it might help you clarify some of these questions there as well. Okay. So next, there is a question about the MINC number. A lot of people are asking about this. Do you have any tips in terms of if they can't find the MINC number? Is there a way to get it, or?
Yeah, it was on I did go to CPSO when I looked at it and was able to find it there. Maybe what we can do is I'm happy to look into that and see what's the easiest way to find it, and then we can circulate it afterwards with the materials.
Okay. Yeah, I think that's a great idea. Actually, we can follow up on that. And do you know if other health professionals aside from physicians can use open evidence? Can nurse
Yeah,
practitioners, for example?
that's a great question. The only thing it asked for was the MINC number. I didn't see any other sort of number that it asked for. So it does say healthcare professionals in terms of who can sign up for that. And so it wasn't specific to physicians. But I'm happy also to follow up on that, and we can ask them. But I did not see any other credential in that area.
Okay. Amazing. Well, certainly maybe we'd encourage our NP colleagues to just try it out, and maybe you can report back to us and let us know in terms of whether or not that worked. Another question here about dictation. So, do any of these AI scribes have real-time dictation features where you can dictate into it? Is there like do the I
They
think
do.
from my own experience they do. Yeah.
Yeah, exactly. They do. Many of them do, and so it does replace dictation, and it also gives you the ability to take that just normal conversation and make a note.
Okay. Awesome. I'm just gonna see here. So one question here is if the name is not associated with the recording, why is privacy in such an issue?
Yeah, so there's a concern about taking the patient information and making the AI model better and using it to train the AI. And in general, part of the challenge is because we have so sophisticated tools, if you don't have the name, you can still re-identify the patient. Like the patient may talk about what neighborhood they live, they might talk about some of the activities that they do, who they associate with. And so it's not just a patient name, it's any other information can be put together to re-identify a patient. So we just need to be cautious about that. And like, you know, when patients are talking to us, they share a lot of information, right? And so it's that other information that can be relevant, that can be used to re-identify the patient. So this is why we need to be just very cautious in terms of not sort of using the data for other purposes where, you know, a patient could be harmed.
Mhm. Yeah, definitely. I think that's really important. And I think sometimes that part of the scribe technology isn't always thought of, right? That like, you know, could you potentially reconstitute what's and put together sort of a profile of this particular person and identify them. So I think that's a really key point. And I think too, that's why that piece around like data staying in Canada is really important too, because you don't want that data crossing into other countries, for example.
Yeah,
Um,
100%.
And so, actually, on that note, the next question is kind of along those lines, which is around like local AI scribe models. So, what I'm assuming is that this question is talking about is if you were able to build your own local model, and why is that not sort of a preference versus sending these to the companies? Is it just logistically that's very difficult, or is there something
Yeah.
beyond that?
Yeah, I think it's like you're leveraging the model that's been developed. These models, you know, are refined and tuned to support the conversations that we have with patients, you know, with the medical data. So if you build your own, like a lot of companies have sprung up that are doing this. Um, how accurate is it? How much does it hallucinate, right? So you know, you could sort of develop, and you know, a lot of these are smaller startup companies, and they've done a good job actually having accurate models. And so you could, I think you could. I think it's how good is it going to be if you sort of have a limit in terms of how you're training that model. Um, so there's an opportunity to do that. I think a lot of them use the models that have been developed and refined over time, and that's why they're so good. And you know, over the last few years that I've been using an AI scribe, I've noticed an improvement in terms of how accurate it is. So you may not see that improvement if you use your local model, but certainly you can. Like certainly you can do that. I'm not sure if the companies would be open to that because it's a different costing structure and you know, it is more challenging for them.
Super interesting though, to hear about these types of opportunities as well. So an interesting point here, I think this is more just around a point for the audience, is that, you know, there's a concern around, you know, does this mean loss of jobs for our support staff in medicine with the use of AI, right? And like, you know, if you are now sort of able to have AI answering the phones and things like that, you know, is there a potential risk that people may lose their jobs? I know you talked about the fact that maybe it frees up your staff to be able to do other things, and I think that's the hope with it, but I think that is sort of the unfortunate kind of double-edged sword to this.
Yeah, well, we're short about 3,000 medical office assistants in Ontario. Over the next few years, we will be short, and so it really is about like closing the gap. And I think as we see more complex patients who need things like more navigation, could we use our staff for that, right? So as we've seen these different revolutions happen, you know, we haven't actually needed less people. We've just needed people to do different things, and I think it's the same thing. You know, my front staff is tremendously you know, able to deal with patients and navigate patients, and they are the front door. And I think we could leverage them in different ways, not replace them.
Definitely. And one last question. I saw it actually come up in the chat, but I thought it was a really good question, which is around like the use of those AI agents. Do you know if it's a standard practice that if you called, like for example, like with the glass pane that you were talking about, that like should it be a standard that they should be upfront with that in the first place? That, you know, when you pick up that it says that it's an AI that's speaking to you. Like, do you know if there's any regulations around that, or should there be regulations around that so patients actually know whether they're talking to a real person versus an AI from the outset?
Yeah, that's a great question. I think there should be like you know, the AI sort of receptionist does let you know that it's an AI agent. The Glasscare company did not let me know that it was an AI agent. So I don't think it's been regulated, but I do think that should be best practice, and I do think it should let you know that you're talking to AI. And you know, we've got to be careful, right? We want to make sure that AI is helping things and not hurting things in terms of managing with patients in the right way. So I do think it should be best practice. I don't think it's regulated.
Okay. Thank you so much. With that, I'm going to turn things over to our final speaker there. Mohammed, there are a few questions in the chat that are actually like pretty like nuanced and specific, so it might be good to just type some answers to those. And then I will just flag for the audience that Mohammed is going to leave at 9 o'clock, so we're not going to bring him back for additional Q&A if we go past 9 a.m. But thank you so much for being here today. And we will turn over things next to Samantha.
Okay, very dramatic change in topic, but here we are. We just come out of an extreme heat event. The image on your screen is from the 2021 BC heat dome event, where there were between 600 and 700 deaths, officially 619. And so I'm here to give an update on how, as family physicians, we can protect our patients from the heat. In that BC heat dome event, 90% of the people who died were over the age of 60, and 98% died indoors. And it was actually the deadliest weather event in Canadian history. And there's a lot that we've learned from the data because the BC coroner decided to track heat-related deaths. So we've learned that, for example, people living with schizophrenia had the greatest increased risk of death of any group, with a threefold mortality compared to average British Columbians. And heat is going to continue to be deadly moving forward. You can go to the next slide. Here in Toronto, we're expecting extreme heat days to more than triple by 2050 compared to a 2005 baseline. And not only that, but the number of very hot days, the warmest maximum temperature is also supposed to increase, and the average duration of each heat wave will increase as well. So next slide. This is just a reminder of heat physiology way back from first year medical school. So internal thermoregulation attempts to maintain a person's core temperature between 36 and 37 degrees, and that's controlled by the hypothalamus. And as the hypothalamus senses changes in body temperature, it signals to the cardiovascular system and the respiratory system to, for the heart to beat faster, for the respiratory rate to increase. And all of this is an attempt to increase blood flow to the periphery so that heat can be dissipated, typically through radiant heat loss. And then as it gets hotter, of course, the human body starts to sweat so that we can start to dissipate heat through evaporative heat loss. Next slide. And then as our bodies get hotter, we start to end up in decompensatory hyperthermia. And that's really heat stroke, where the core body temperature hits that 40 degrees Celsius mark, and we're no longer able to cool the body down. And so then there's inadequate cardiac output, and there's this vicious circle of increasing temperatures, thermoregulatory failure, cellular stress, and an inflammatory response. And that's why classic heat stroke has a 50% mortality rate. Next slide. And this is a reminder, signs and symptoms of heat exhaustion and heat stroke, quite nonspecific, feeling weak, feeling nauseous, maybe experiencing muscle cramps. And then really the differentiating symptom between heat exhaustion and heat stroke is change in mental status. And the differentiating sign is a core body temperature of 40 degrees or above. You can click through. And morbidity and mortality is directly related to the duration of the hyperthermia. So, if you're presented with a patient or if you're out in the community and you suspect that someone is experiencing heat stroke with that change in mental status, immediately you need to cool them down, get them into a cool environment, apply ice packs, and get that body to cool down. Next slide, or sorry, click through. Back, yeah. And heat also exacerbates underlying chronic conditions. So it doesn't only lead to heat exhaustion and heat stroke, but because the heart is beating faster, because there are signals to the respiratory system to breathe faster, it can exacerbate chronic conditions like asthma, heart disease, also worsens diabetes control, and can worsen underlying chronic kidney disease. And it can also exacerbate underlying mental illness. And there's actually documented increases in suicide attempts during extreme heat and an increase in violent crime. Next slide. There's also impacts on the health system. So during the BC Heat Dome event, Vancouver Fire Rescue Services reported a threefold increase in call volumes and wait times of up to 11 hours for ambulances. And there were also infrastructure failures actually throughout British Columbia with overheated hospitals, non-functional ambulances, and then there were many institutions that lacked cooling. So long-term care homes and mental health institutions were really struggling. And this is a risk here in Ontario as well. Next slide. So what can we do as family physicians? This is a these are 3 steps that we can take. So first we need to identify which of our patients are most at risk of heat-related illness. Then we can advise those patients on how to protect themselves. And finally, we can advocate for tools and policies to reduce risk. So first, we'll identify those at risk. So who is at risk of heat-related illness? Well, first, there are those who are more exposed to the heat. So that would be outdoor workers, people experiencing homelessness, and then anyone who lacks access to indoor cooling devices. And that would include people in prisons and long-term care facilities without air conditioning, people in homeless shelters that don't have air conditioning, but really anyone who doesn't have air conditioning. And that exclamation mark on your screen is just that in urban environments, the urban heat island effect leads to up to a 15 degrees higher surface temperature compared to nearby neighborhoods with adequate green space. So this is an important actually point for intervention on a policy level, is to plant more trees. Next slide. Who else is at risk? People who are more sensitive to the heat. So you already heard that, the majority of people who died in the BC heat dome were over the age of 60. So seniors are certainly more at risk. Also babies and very young children, people who are pregnant, anyone with those chronic illnesses and mental health conditions, people who use drugs, especially stimulants, and then users of heat sensitizing medications. So it's really medications that interfere with that normal heat physiology. So beta blockers, diuretics, antihistamines, also antidepressants and antipsychotics, which are thought to directly influence the working of the hypothalamus, and then lithium as well. Next slide. And then also anyone who lacks access to appropriate resources or information. So, people who are experiencing homeless and maybe living in a tent. Also anyone who has a language barrier and may not be accessing information about the heat. All right, next slide. So what can we do? Well, we can advise our patients on, appropriate measures to cool themselves down. And there's evidence that the majority of people, even older adults who we see, do not think of themselves as personally at risk in the heat. So there is research that shows that providing preventative messaging, especially for older adults, does change behavior. So in an Australian study, there was a 63% lower chance of heat-related illness in those who were provided, just this kind of information. This is a screenshot from a City of Toronto webpage on how, everyday people can beat the heat. A couple of things, this is probably very obvious, but a couple of things include, not using the oven or other heat generating devices in the house, remembering to block the sun during the day with blinds or even just cardboard if there are no blinds available, and then opening a couple of windows at a time so that you can generate a cross breeze. And that QR code takes you to a resource that was just linked to in the chat that, provides some good an outline of what to do in case of heat. Next slide. We can also direct our patients to find a cool space. This is also from the City of Toronto website, and there are other municipalities that provide similar information. So there's a directory on the city website of cool indoor spaces like community centers, libraries, shopping malls. Unfortunately, at the moment, we do not have 24/7 cooling centers, even during extreme heat, but this is something that's being advocated for. And, unfortunately, there are barriers to visiting cooling centers for a lot of people, especially those folks who are most at risk of heat-related illness. There's the need to travel. There's also that tendency not to view oneself as vulnerable that I already mentioned. And there's also potential for stigma. So it is something that we need to work towards, ensuring that cooling centers are accessible and inclusive, and potentially also desirable places to be by providing programming or meals. Next slide. This is a report that was published by Acorn Canada just a few weeks ago. 44% of tenants in Ontario do not have access to air conditioning. 44%. Next slide. So what can we do about it? Well, we can actually prescribe air conditioning. Anyone who is receiving social assistance, Ontario Works or ODSP, is eligible for up to $400 in funding for a cooling device, whether that's an air conditioner or a fan. We need to write a note that says they have a medical condition that makes the air conditioner necessary. And then the patient or client needs to then go to their worker and present the cost of what that device might be. So if you go to that QR code, there's a letter template that you can use, and then you can prescribe air conditioning to your patients on social assistance. And, I found myself the last 3 days asking everyone, do you have an air conditioner? Do you want me to write you a note for one? Next slide. There are other programs available for people who are not on OW and ODSP. I'm not sure about other municipalities, but in the city of Toronto, there's a hardship fund that people can apply to. And there's actually a brand new air conditioner assistance program, although I think it's full up now. It was only for 500 seniors in Toronto who are not on OW or ODSP. Next slide. And then finally, we can advocate. So next slide. This is a joint statement released or led by the Canadian Environmental Law Association calling for a maximum indoor temperature bylaw. It was shown in British Columbia that when indoor temperatures were less than 26 degrees, there were no deaths. And other studies in other jurisdictions have found similar results. And so that's why there is this call for a 26-degree maximum indoor temperature for tenants. We have a minimum indoor air temperature in the winter, and to save lives, we do need this 26-degree maximum indoor air temperature, in particular because of the mobility challenges and mental health challenges getting to cooling centers for those who are most vulnerable. Next slide. And then, we can also demand action for workers, especially farm workers. Farm workers die from heat stroke at a rate 20 times that of workers overall. And so we do need solutions and interventions to protect outdoor workers. That tree is just to remind us about that urban heat island effect, and we can plant trees and it literally cools the environment as well as sinking carbon into the ground. And then at the bottom there, that's a picture of a green roof, because by implementing passive cooling that does not require electricity, we're actually becoming more resilient, because then if there's a power failure, the building can remain cool through things like green roofs, planting trees, and there are other passive cooling techniques that can be built. And then obviously, we do need action on the climate crisis. We need to stop burning fossil fuels because we can only adapt so much. Thank you. That's my last slide.
Amazing. Thank you so much for that overview, and definitely some great things to think about here as well. I guess, I see one comment here around like the fact that like just the letters themselves, and, is there an opportunity for advocacy around, perhaps not having that step of having the family physician write the letter, right? Just because
I
there is
agree.
an administrative burden that comes with that. Obviously, there is a need for people to have AC, but do you actually need a medical degree to, tell the ODSP that, right?
No, I completely agree. Why are we acting as gatekeepers here for a device that is clearly needed?
Definitely. And as you argue, right, it's a life-saving device as well too, really. And then in terms of I guess in teaching like workplaces, schools, and people about altering ways to not be in a intense heated environment, is there any opportunities for us to be involved in that? Like, what is the role in there?
Yeah, for schools, for sure. I mean, the schools need to be retrofitted. Like, we do know that, as I mentioned, extreme heat is expected to triple. This may have been or may be set to be the hottest summer on record, but it's the coolest summer that you will experience moving forward. So, summer is going to happen again and again, and extreme heat will happen again and again. And we just need to invest in our schools and other public institutions like long-term care facilities and make sure that there's cooling available.
Yeah, I think that's such a key point, right? Because as you said, it's only likely to get worse, like based on all the data that we have. So we need to start planning for this, right? It's not this is a one-off, unprecedented summer situation. This is going to be the norm, unfortunately, moving forward. So you're absolutely right. We need to plan for that. And then curious about any guidance on sporting competitions. Like, should there not be public health advisories to guide this and when they need to be canceled? Because often it seems to be a little bit discretionary.
Yeah, so many sporting institutions do actually, and have for many years, use something called the wet bulb temperature, which takes into account the air temperature, the humidity, radiant heat from the sun, and wind. I mean, FIFA has been using that for over a decade. The U.S. military uses it to determine whether they're going to go ahead with some of their activities because it's directly correlated with health outcomes. I mean, I agree for more community-based sports activities, we do need to be thinking about when to cancel because it's clear that, when there's hot outdoor temperature, we can also develop heat stroke with exertion.
Definitely. And then I see some requests for the letter template here. So just to
Yep.
remind everyone, we do send out all the links, all the resources out as well too. So don't worry, that will be circulated for you. But I think it's a good opportunity to highlight that. So, unfortunately right now we can't change the ODSP system, but fortunately Dr. Green's shared a really helpful template that we can put into our EMRs to help make that letter writing easier. And I will say, when we have the opportunities to advocate for someone and be able to provide them with something like that, it does feel good. So hopefully at least this template can be a little bit helpful to ease that burden, but certainly agree that it would be really nice to have that taken off of our plates because I agree that it doesn't need a medical degree per se. And then in terms of other things, yeah, some people just talking about the fact that the schools themselves are not cooled, and I witnessed that myself as well too with my partner because she works in a local public school and as a kindergarten teacher, and she was telling me about the fact that there wasn't working AC, which seemed very alarming to me.
Well, and
So.
like learning outcomes are poor.
Mhm.
Test scores drop by 50% once the temperature rises above 100 degrees Fahrenheit in a New York City study. So yeah, we do need to retrofit so that our kids can continue to learn. And I see a question about lifestyle changes in other countries. So it's interesting. We actually adapt physiologically to the heat. It takes about 2 weeks. So early extreme heat, like we just experienced, and like the BC heat dome in 2021, is the most dangerous because our bodies are literally not physiologically adapted yet. But over the course of the summer, our bodies actually become more adapted and are better at responding to high outdoor temperatures. But yes, I think maybe we're referring to like midday breaks, midday naps, the siesta. That's also something to consider.
Definitely. Yeah, it was interesting. Like, as you were talking, it was making me think about like countries like Australia, for example, right? Where they have this extremes of temperature, right? And interestingly, there, AC isn't always as common, right, in those places. But I wonder if part of it is that physiological adaptation that you're referring to, right? Because they've been exposed to that for so long. Something of interest. I'm not expecting you to have an answer to that per se.
Yeah, well, and also I think the improved passive cooling in their built infrastructure. We have a lot of these like concrete tower blocks built in the 60s
Hmm.
that are completely terribly adapted to the heat.
That's very true. And there's lots of nice wind coming from the sea as well, which I'm sure helps as well, right? Amazing. Okay, well, I think we got actually amazingly to the end of our questions. I can't remember the last time we did that, so that's amazing. So I'm just gonna pull up the slides just to close things out for us. So just a reminder, if you are interested in other communities of practice to our audience today, there are some other sessions coming up from the Practicing Well group, and there's also the Peer Connect Mentorship Program, which can both be very helpful for supporting you with education and mentorship and support around mental health, addictions, and chronic pain. So feel free to check those out as well too. They're excellent. Next slide. If you are interested in seeing some of our previous sessions, we do have them all recorded. You can check them out. And just remember, too, that if you do take the time to watch a pre-recorded session, then make sure to also do the self-learning tool that comes with it. That will allow you to claim a CME credit for taking the time to do it. So make sure to do the self-learning part. It's very easy and quick to do. And we do have some instructions about that on our website as well. Next slide. So please attend our upcoming sessions. I'm going to definitely highlight the July 18th one that's coming up because I know it's in the summer, but I would encourage you all to attend this one because in addition to having an infectious disease update, we're actually inviting the Looney doctor, who I'm sure many of you are familiar with, Dr. Mark Soth, who's going to be talking about the pension plans. We heard a lot of feedback and interest around learning a bit more about pension plans and retirement planning for physicians. So we've organized this session over the summer. So we would really encourage you all to attend that one because I'm sure it'll be really interesting to you all. And so with that, I believe we have our next slide here to close out. So thank you all again for attending today's session. I hope you have a wonderful rest of your weekend and that you enjoy the nice weather as well. Stay cool out there, and we look forward to seeing you in July. Thank you so much and have a great day.